Hi, my name is Brian Apavu. I am a neurologist with an interest in philosophy, the mind, and living the examined life. Today, I want to dive into another epilepsy condition that I have seen commonly in my practice in children, and it's currently referred to as self-limited epilepsy with centrotemporal spikes. The acronym is SeLECTS. The condition has had a number of name changes, so you may have heard of it with different names, which include benign Rolandic epilepsy or benign epilepsy with centrotemporal spikes, which was referred to as BECTS. Self-limited epilepsy with centrotemporal spikes is the most common epilepsy syndrome, the most common focal epilepsy syndrome seen in children. It is characterized by brief, infrequent focal seizures, typically involving the face, a facial sensomotor symptom, where children will often have numbness in one side of their face, some clonic movement. It's hard for me to imitate it, but like a clonic movement of the face, some speech arrest, and actually some drooling on one side. And often occurs during sleep or upon wakening. The most frequent sort of way that I hear about these kind of patients is the parents wake up and find their child with a facial droop involving one side and unilateral drooping. Some families can be really worried that their child had a stroke based on the symptoms. Oftentimes, it will have that twitching associated with it, but not always. And that's just a common type of seizure that's seen with self-limited epilepsy with centrotemporal spikes. Sometimes it can manifest with generalized tonic-clonic seizures, and these focal seizures can progress from that facial twitching to more convulsive activity as well. So that's something to bear in mind. The incident and age of onset regarding this condition, self-limited epilepsy with centrotemporal spikes accounts for 15 to 25% of childhood epilepsies, with a typical onset between 3 to 13 years of age, peaking around 7 to 9 years of age. The seizures with self-limited epilepsy with centrotemporal spikes are usually brief, nocturnal, and they can secondary generalize, like I mentioned. They can sometimes go from just the facial twitching to generalized tonic-clonic activity. And like I mentioned, the semiology includes the facial twitching, the speech arrest, behavioral arrest, and hypersalivation or drooling on one side typically. Most of these children have normal neurologic development up until the point that they have the seizures, and you often notice that's what's noticed during and after the seizure occur. But a significant proportion have comorbidities such as attention deficit hyperactivity disorder, learning difficulties, and mild cognitive or behavioral disturbances that we need to be mindful of. The mechanism of disease in self-limited epilepsy with centrotemporal spikes is primarily attributed to being age dependent and related to non-lesional cortical hyperexcitability in the centrotemporal regions of the brain, or the Rolandic regions of the brain, where there's close to the sensory motoric cortices. And there's thought that there's a central role for abnormal thalamocortical circuit function during the seizures. The hyperexcitability manifests as frequent interictal epileptiform discharges. Particularly, you can see these during sleep on the EEG, and this disrupts the normal neurodevelopmental process and network maturation in the brain. The condition is generally considered mild, and it has an excellent long-term neurologic prognosis. However, some neuropsychological conditions, like such as ADHD, mood disorders, and learning difficulties, have been common during the active phase, during the childhood years where these seizures are occurring, although studies that show long-term cognitive outcomes in these children seem to show that there's generally a favorable outcome in the long run. Quantitative magnetic resonance imaging studies have shown altered cortical thickness, subcortical volumes, and altered white matter microstructure in children with self-limited epilepsy with centrotemporal spikes when you compare them to healthy controls. These abnormalities are most prominent in the frontal, temporal, and perirolandic regions and are present at or near the time of diagnosis. Children with self-limited epilepsy with centrotemporal spikes have been shown to exhibit thinner cortices in the frontal, temporal, and occipital brain regions, as well as larger putamental volumes, and with these structural differences persisting or evolving over time. These changes are associated with persistent cognitive deficits in neuropsychological studies, particularly in language, memory, and psychomotor speed domains. Most children with self-limited epilepsy with centrotemporal spikes live normal lives with minimal restriction, but the majority of them do achieve seizure remission by the time that they're teenagers. It's considered a self-limited disease, and such that's part of the title: self-limited epilepsy with centrotemporal spikes, with spontaneous remission typically occurring before adulthood. The treatment of this condition varies among different neurologists and epileptologists. Many neurologists and epileptologists don't use anti-seizure medication routinely for children with self-limited epilepsy with centrotemporal spikes unless the seizures are frequent or disrupted. When treatment is indicated, there are medications like levetiracetam or Keppra or clobazam or Onfi are preferred, and then some studies suggest that the seizure medication, anti-seizure medication that are better for focal epilepsy, such as oxcarbazepine, might be a little bit less effective and may worsen cognitive outcomes in some cases. The studies are really limited. A number of us do use oxcarbazepine without major issues for patients with this because it's often a focal epilepsy condition. Some polytherapy using more than one seizure medication for this condition, as well as the use of valproic acid, has been associated with poor cognitive outcomes and is generally recommended to be avoided for this condition. And then treating the EEG, treating the high amount of epileptiform activity that we see in sleep isn't really warranted unless there's a concern that the patient may have what we call electrical status epilepticus in sleep, which is something I'll talk about at a later point. Some physicians do advocate for the use of maintenance anti-seizure medications in self-limited epilepsy with centrotemporal spike, particularly if the seizures are very burdensome and there's a high seizure burden. There was a recent study published in JAMA Neurology that reported that there is a small but noticeable incidence of sudden unexpected death in epilepsy, SUDEP, in patients with this condition. The study identified 3 cases among a cohort of children in a SUDEP database in North America, the North American SUDEP Registry, and highlighted that while SUDEP is very rare in select epilepsy, self-limited epilepsy with centrotemporal spikes, it can occur and should be considered as part of clinical discussions and treatment decisions. The study did not provide a population-based incident rate, but the identification of these cases demonstrate that SUDEP is possible, and you should take that in mind when you consider the use of anti-seizure medications for this condition, particularly if your child's seizure burden is quite high. There are misconceptions with self-limited epilepsy with centrotemporal spikes. The term benign in previous definitions, such as benign Rolandic epilepsy or benign epilepsy with centrotemporal spikes. The term benign can be misleading. While the seizures remit, neuropsychological and behavioral comorbidities can be frequent and may impact academic performance as well as quality of life. This syndrome is not necessarily always pharmacoresponsive, and therefore overtreatment with anti-seizure medications should be avoided. So I hope you found this video helpful. If you did, please like this video. And if you're watching it on YouTube, subscribe to my channel. If you're looking at it, Nostr, a like and a follow would be wonderful and greatly appreciated. I thank you for your time and hope you're having a wonderful day.